Well, one of the nicest things about coming tonight, it was still light out instead of being dark at this time of the day. So that was kind of nice. Tonight we have two very knowledgeable speakers that are going to help us understand a little bit more about how powerful we really can be in preventing diabetes. A lot of times I think people just assume this is just something that's going to happen and we're going to walk away from here knowing exactly how much we can do, and that includes taking care of our feet and preventing problems with that. So we're going to start tonight by hearing from Dr. Cynthia Williams. She received her bachelor's degree in human nutrition from Ohio State University in 1987. She graduated from Ohio State University Medical School in 1991 and went on to be an intern at St. Mary Medical Center, UCLA College of Medicine in Long Beach. She received the Outstanding Ambulatory Care Resident Award from St. Mary Medical Center in 1993, and in 1994 completed a clinical endocrinology fellowship at Harbor UCLA Medical Center. Between 1997 and 2000, Dr. Williams was on the active staff at Huntington Memorial Hospital in Pasadena. During this time, she served as the director of the Metabolic Bone Clinic and the Insulin Pump Program at the City of Hope National Medical Center. Dr. Williams is now the director of diabetes care at Torrance Memorial Medical Center. She is board certified in internal medicine and endocrinology, and she sees patients with thyroid and weight issues, metabolic syndrome, diabetes, and other hormone-related issues. She is a popular speaker on diverse topics, including weight management and hormone balancing. She has co-authored and authored several publications in the endocrinology field and is also active in sponsored research in the fields of diabetes prevention and insulin studies. Please welcome Dr. Williams.
Thank you. The first thing I'm going to do tomorrow morning is make an appointment with myself. I think I need a good doctor. Anyway, thank you for having me tonight. I'm excited to be here to talk about diabetes. And we're talking about preventing. The topic is broad tonight. We're talking about preventing diabetes, but we also are going to be talking about diabetes in general. And there, as many of you know, there are two types of diabetes, type 1 and type 2, although it turns out that when it gets right down to it, there are shades of gray. So I imported slides from the American Diabetes Association, and one of my goals for all of you here tonight is to walk away with some new tools or new ideas to help empower you to take charge of your own health, whether you're concerned about becoming a diabetic, whether you're newly diagnosed diabetic, or whether you're an individual who's had diabetes for a number of years. I'm going to be reviewing some of the newest technology, which is super exciting. So American Diabetes Association has a number of free guides available, and we can help resource that for you if you'd like. So part of the American Diabetes Association program and the Torrance Memorial Certified Diabetes Education Program is to review what we call the diabetes ABCs. What is diabetes? Getting the best care for your diabetes, learning about blood glucose and how to manage your blood glucose, how to plan healthy meals. We learn about physical activity and losing weight. There are programs to help us develop new habits. Medications is becoming increasingly complicated and expensive, unfortunately. Dr. Shum tonight will be talking about complications of diabetes and foot care. So first of all, what is diabetes? Diabetes is a metabolic disease where the blood sugar, the sugar level in the blood is elevated. Diabetes takes approximately a decade to develop for type 2 diabetes. Type 2 is the typical person with adult onset. The average adult who develops diabetes has type 2 diabetes. When a person, after years and years, maybe up to a decade, of what we call insulin resistance, when their pancreas can no longer keep up with their blood sugar, with their metabolic demands, they're deficient in insulin and their blood sugar levels are elevated. So the blood glucose level is higher than normal. I think, how many of you had a blood sugar level done today? Right, most of you. So depending on what time we've had our last meal, normal blood sugars range from 60 to 140. And kind of a classic phrase that we use is the person who has normal glucose metabolism, that the individual has normal pancreatic function, no matter what they eat, can't push their glucose over 140. So if we check that individual who's insulin sensitive, they're young, they're active, they have a normal body weight, and let's say they don't have any diabetes in their family, they can chow down on a cake and soda and eat poorly, and their blood sugar will never go over 140. But for most of us, with age and with time, we become more resistant to our insulin, and with a variety of risk factors such as obesity, age, decreased physical activity, with increasing glycemic loads in our diet, we can push our blood sugars up over 140, 150, 170, 180. We diagnose diabetes when that blood sugar reaches 200. The other blood sugar reading we look at when we're diagnosing diabetes is a first morning blood sugar of 126. So again, when we're young and healthy, our first morning blood sugar never goes over 100, but when we're diagnosed with diabetes, that morning blood sugar is 126. So it's not a big difference, right? Healthy normal is under 100, diabetics over 126. So the doctors now, with the lab results, are really instructed to notify you if your blood sugar is over 100 in the morning, because then we can start talking about, hey, how can you help prevent diabetes? Type 1 diabetes is autoimmune diabetes, and that's where we typically see that we talk about a juvenile onset diabetic. That's where someone has antibodies that attack their pancreas. So the precursor to that can be one or 2 weeks, and the individual may present, usually it's a young adult or a child with very high blood sugars of, let's say, 500. All of a sudden they were perfectly healthy 3 weeks ago, and then they're sick with a blood sugar of 500. However, what we're realizing is that adults who are diagnosed with diabetes can also have type 1 diabetes. And my oldest patient that I ever diagnosed with type 1 diabetes was 87 years old. Yeah, and the reason I knew she was type 1 is there are blood tests that we can do, and we measure antibodies. We now have recognized at least 5 different antibodies that can attack the insulin or attack the pancreas and the beta cell. So we now can measure these antibodies. If an individual is antibody positive, then they do better they need insulin replacement. So this 87-year-old gal, who then was dependent on insulin, was, I would say, complaining to me one day about having to check her blood sugar before each meal and to use insulin before each meal, and she had to use a long-acting insulin and a mealtime insulin. And I said to her, she said, isn't there any other way? Is there any other way? And I said, no, you don't make insulin. You're dependent on the insulin injections. And she just kept complaining about that. I don't want to do this. And I said, well, you know what? At least you weren't diagnosed when you were 10, like some of my patients, or 3, or 12. You're diagnosed at age 87. So you have to do what you have to do. Type 2 diabetes, I mentioned, of course, is the most common form. It's typically diagnosed in adults. There's a strong genetic component, and we're seeing type 2 diabetes now, and even kids as early as the age of 10 or 12, and of course all the way up the chain. In a lifetime, a woman's risk of developing diabetes is nearly 40%. So ultimately, if we're lucky enough to live long enough, it's not unusual for the pancreas to get a little sluggish and the pancreas can't quite keep up. Perhaps in our 7th decade of life or 8th decade of life, and it's common for women to develop diabetes. Men, the lifetime risk for developing diabetes is close to 30%. So, and then gestational diabetes is diabetes that's diagnosed during pregnancy. So most people with type 2 diabetes have insulin resistance. How many of you are familiar with that term? So insulin resistance, our insulin is like a transporter. It moves the glucose out of the blood from our gut, out of the bloodstream and into our cells. So it moves the glucose into our muscle cells if we're using our muscles. If we're not using our muscles and we're eating and we have a lot of sugar, the insulin will take that glucose and put it into our fat cells, and then we'll become more fat. It takes some of the glucose and puts it into the liver and the kidney, and we store glucose in the form of glycogen in the liver and the kidney. So what happens with insulin resistance is the insulin, instead of being really efficient in grabbing the glucose, it can't quite grab it, it can't do the job. And the things that cause insulin resistance are sedentary lifestyle and high-fat diets, for example, are some of the things. If an individual becomes obese, so some people, especially more, we see this in an Asian population, they may be just 15 pounds overweight and they'll be insulin resistant. Other people with different genetics can be 50 pounds overweight before they develop insulin resistance. And some of the predisposition for insulin resistance develops in utero. So, for example, I saw a patient the other day in my office, and she was a 42-year-old woman who is an athlete, trim, healthy, athletic, and she wanted to know why her blood sugar was a little elevated. And we had done some more sophisticated tests, hormone levels and what we call some neuropeptide levels. And we measured an insulin level and what's called a C-peptide level, and then an adiponectin level. And it turns out that she was insulin resistant. So she's thinking, how can I be insulin resistant? I'm fit. She was very trim. She was very active. She didn't eat any sweets. She was pretty much a vegetarian, very healthy lifestyle. And I said, well, tell me about your mom. And her mother was a diabetic who developed heart disease in her 50s, and her mother eventually died around age 60 of heart disease. But she said my mother had a big belly, skinny legs, she smoked and she drank, and she had a terrible diet. And we now know that when a fetus is developing in the mother's uterus, that certain factors impact that child for the rest of their life. So if a woman smokes during pregnancy, that her baby will be more insulin resistant. If the woman is overweight or obese during her pregnancy, that her child would be has more likely to struggle with lifelong obesity. And another example to illustrate this point, I saw a woman who came to see me once for a lifelong history of weight problems. She was, over 300 pounds, and every doctor, she's probably around late 50s, and every doctor she had seen had, told her to lose weight, and, the same old thing. And the first question I asked her is, I said, well, tell me about when you were born, how much did you weigh when you were born? And she said, well, I was a preemie twin. And when I was born, I weighed 2.5 pounds. And she was the B twin. So the A twin is the dominant twin, and the B twin is the smaller twin. So what does that twin, the smaller twin in utero, what does that baby have to do? Has to survive. Everything is about grabbing every little piece of nutrition and making that muscle and fat so that baby, that preemie, can survive. So then when they're born premature, they're tiny. Again, the first 3, 6, 12 months of their lives, all about gaining weight. Right? So this gal had a lifelong battle with obesity, much of it programmed in utero. And you can imagine the burden that sort of takes off her emotionally, So when we're talking about preventing diabetes, we do need to be talking about educating women and helping women before they become pregnant. So that has a huge impact on whether or not their offspring will develop diabetes. Now, one thing I want to impress upon you is that if you're an individual with diabetes or you're concerned about preventing diabetes, it really is going to be up to you. Every day you'll make decisions that can impact whether or not you're going to develop diabetes, or if you have diabetes, how your blood sugars will run. So you have choices about what you choose to eat, building physical activity into our routine, taking medications, keeping track of your blood sugar, blood pressure, and cholesterol numbers. And then, of course, it's important to learn all that you can about diabetes. If you are diabetic, or if you're at risk for diabetes, we all should know what our A1C is. And a diabetic A1C is 6.5 or higher. We're now notifying our patients if their A1C is 5.7 and between 6.4. So if a hemoglobin A1C is 5.7 or higher, we let that person know, hey, you're at risk for diabetes. And now I've even seen at the bus stops, are you preventing diabetes? Are you at risk for diabetes? Or do you have prediabetes.org? So we need to know our A1C regularly, and I would recommend that be done with an annual physical. I'll talk a little bit more about blood pressure, and I'll talk a little bit more about cholesterol. But those 3 factors can significantly impact your risk, your likelihood of developing, first of all, diabetes, heart disease, stroke, and cancer. So paying attention to these ABCs is applicable to virtually every single person sitting in this room. The A1C provides an average blood sugar reading for the past 2 to 3 months. For someone with diabetes, the American Diabetes Association recommends 7. The Endocrine Society recommends as normal as possible if we can treat that individual without developing hypoglycemia. And if you're diabetic, you should have this measured 4 times a year. If you're at risk for diabetes, twice a year. Otherwise, once a year with your annual physical. I think everyone with diabetes or who is at risk, who's been told they're pre-diabetic, should know what their target is, and they should know their results. So when I see patients in my office, I tell them the number and I give them a copy of their lab results. And then they say, well, I don't want a copy of my results. I'm like, no, here's a copy of your result. Here's your test. Here's your result. This is what our target is. This is what our goal is for next time. And I review that with people. You're at the end of the day, you need to be responsible, for knowing your numbers. Blood pressure, I'm sure some of you saw earlier this year about the new blood pressure goals. How many of you remember reading in the paper about the blood pressure goals being tighter? What they have now done is lowered our target blood pressure. Target normal blood pressure is 120/70. Hypertension is over 135. And the reason that these blood pressure ranges were lowered is that when the epidemiologists, or people who look at, disease outcomes, what they found is that the risk of stroke or heart attack was 4-fold higher if your blood pressure ran 140 versus 120. So if you walk into the doctor's office and your blood pressure the last 3 visits was in the 140s versus the 120s, you have 4 times the risk of having a heart attack or stroke. And along those lines, if you bring your blood pressure down from 140 to 120, you reduce your risk of heart attack and stroke. And it's a little secret in the endocrinology world. We talk about blood sugar, blood sugar, blood sugar, and blood sugar is super important. But when it comes to your eyes and your kidneys, blood pressure is almost more important. So blood pressure is very important. Every year or every other year I alternate conferences, but I go to the cardiovascular symposium and metabolic symposium, and and it's a big diabetes conference, but they spent a ton of time talking about blood pressure and how to measure blood pressure, and that'll probably come up in some of the questions and answers. How do you do that? But really, blood pressure monitoring should be as dynamic almost as blood sugar monitoring. So people check their blood sugars several times daily. Honestly, we probably, for those people who have hypertension or pre-hypertension, they should be looking at their blood pressure too. So that means checking your blood pressure with one of those cuffs. So I would know what your blood pressure is, and it's important to know what your blood pressure is running and ask your doctor what you can do about it. The average person who's diagnosed with hypertension or elevated blood pressure needs between 3 and 4 medications to get to a target blood pressure. So it's expensive to treat hypertension. It's usually what we call polypharmacy. Multiple medications are needed. So there definitely is some, kickback when it comes to talking about getting to blood pressure goal. Okay, and then we're going to talk about cholesterol. I think most of you are familiar with the HDL, LDL, and triglycerides. Triglycerides are a more simple molecule, kind of simple fats in the blood. Actually, if the triglycerides are high in the blood, it's like cream in your blood. So we can, in the office, we'll draw someone's blood and then we spin it. And usually the cells deposit at the bottom, and then there's a clear serum at the top. If someone has high triglycerides, it will actually look like cream. You can see it. We hold it up. And they'll say, Dr. Williams, and they'll show me the tube. And I say, uh-oh, Or if we look in the back of the eye, sometimes where you can see the tiny little capillaries, you actually can see it looks sort of creamy. It looks white if the triglycerides are high. And triglycerides elevate if someone is insulin resistant. If there's a genetic component, alcohol raises triglycerides, sweets raise triglyceride, high blood sugars raise triglycerides. I talked about some people have a strong genetic component to high triglycerides. But triglycerides traditionally, for most people, respond dramatically to reducing the number of calories that we eat. HDL and LDL are cholesterol particles, and they are determined, of course, by diet and weight and age and hormones, etc. But there's a higher genetic component to what an individual's HDL and LDL are. So when I look at a cholesterol panel out of a patient, I don't even notice like the total cholesterol. People say, well, what's my total cholesterol is 250. What I'll do is look at what's called the non-HDL cholesterol, which is the total number of not HDL particles. So the total number of per se bad particles, and we'll talk about a non-HDL target of under 100 is a really aggressive goal. So that can be a discussion to have with your physician. You just don't want to know your total cholesterol. You want to know the components. Do I have a lot of the good cholesterol? Do I have high triglycerides? Do I have high LDL? And the LDL is the one that's treated with statins. We've all heard about statins, and you've been to other conferences and lectures on the role of statins. But the statin drugs lower the LDL and have a small impact on triglycerides. We do talk about an LDL goal of below 100, but there definitely is a lot of discussion for people with diabetes or high risk for stroke and heart attack or pre-existing stents. We want that LDL under 70. And HDL above 50 or 40. Patients always say, how can I raise my HDL? And I say, pick new parents. So that one's highly genetically predisposed. So that's harder to treat, and all the pharmaceutical drugs that have tried to raise HDL have not come to market because they were not effective in reducing heart attacks and strokes. And ideally, we want to see triglycerides. This says 150. Ideally, triglycerides should be below 126. And when we're really young and healthy, our fasting, which a fasting triglyceride should be less than 70. So I think all of us in this room should know what our cholesterol was and those individual components, the triglycerides, HDL, and LDL. And there's a term that we use for, in endocrinology called an EWAT, and that's the women with elevated increased waist circumference and elevated triglycerides. So if a woman had a waist circumference of greater than 31 inches and triglycerides of over 125, they were an EWAT. And an EWAT had a almost threefold higher risk of heart disease. So when I'm reviewing lab results with patients, I talk about that EWAT data, but we really want the triglycerides under 126. If they're not, weight loss and changing the component of your diet really can make an impact. So I'm going to skip over this. Now let's get to some of the fun stuff. I'm going to review just some of the new updates in diabetes, which is super exciting. I'm sure many of you have heard about all the developments in diabetes, and I always say, if we can make a driverless car, then we should be able to normalize blood sugars. Technology is looking at an artificial implanted pancreas using what we call nanotechnology. This is being done at UCSF, and it's a tiny, this little device that can be implanted and secrete insulin, and then they package it so that the antibodies cannot attack this device. There are medications now called GLP-1s, glucagon-like peptide factor 1s, that slow glucose absorption from the gut. They increase the insulin from the pancreas when the glucose is high. They lower glucagon. We haven't talked about glucagon, but glucagon is abnormally elevated in individuals with diabetes. It reduces appetite, increases what we call beta cell mass. Those are the cells that make insulin, increase first phase insulin release, and reduce all-cause mortality and reduce the risk of what we call MACE, major heart attacks and strokes, and do not cause low blood sugars. So everyone says, that sounds great. And now these injections, brand names are Bydureon and Trulicity, and the newest one is Ozempic. They're once-weekly injections. Sounds great. What's the downside? The downside is the price tag. These medications retail about $600 a month, unfortunately. And then the other downside is that anywhere between 10 and 25% of individuals have nausea, which is unpleasant, and the drug discontinuation rate is about 10%. But they're wonderful medications. Unfortunately, they're not affordable for most. So I'm going to skip over that. This is another super cool thing. It's a smart insulin patch. It's a patch that is smaller than a postage stamps, and it's covered with 100 microneedles, and it's put on the skin. And when glucose is elevated, it releases an enzyme that breaks down around the microneedle and causes the insulin to release. So this patch is actively being developed and is super exciting. There also is another product. Where is this one being developed? I'm not sure. But it's a glucose responsive insulin. Basically, again, it's an insulin that's injected subcutaneously once a day. And when the blood sugar is high in the system, again, it activates an enzyme, which then breaks down the bubbles that the insulin is contained in. And so the insulin is released depending on how high the blood sugar is. So it's called glucose responsive insulin, and that is actively being developed and absolutely would be a game changer, because right now we're limited when someone needs to use insulin injections. The limiting factor is that insulin is always there. So if they're out exercising or skiing or hiking, or they skip a meal, that insulin is still there, and then their blood sugar can become dangerously low. So a smart insulin is unbelievable. We have people with diabetes are using insulin pens now. They carry their pens in their purse and they'll use their insulin with meals, etc. Now we have pens that help keep track of your last dose, your last blood sugar. You can tell the pen, you can program on your smartphone how many carbs you're going to eat, and it will help calculate your dose. So this sort of thing only used to be available for insulin pumps, and this company called Intuit brought their smart pen to market within the last year. It's been a little slow on the takeoff because it uses insulin they're cartridges, and people like their disposable pens. But it's a super nice device. We now have continuous glucose sensors that can be the size of a Band-Aid, or the Dexcom is a company that's brought to market a continuous glucose sensor, which basically is this device about the size of a, I don't know, it's pretty small, and you adhere it to your skin, and there's a little catheter that goes subcutaneously, and you leave it on for 14 days, and it can literally tell you what your blood sugar is continuously. So unfortunately, I just gave a deposition in a case of a patient who wasn't monitored. Her blood sugars weren't monitored in the nursing home, and the attorneys didn't even know what a continuous glucose sensor is. And I said, well, we can know what the blood sugars are all the time. So when I see patients now, most of my type 1s are on a continuous glucose sensor, and they love it. So it's now covered by Medicare, it's now covered by most insurances, and now we have a new territory for parents or spouses of people with type 1. They can actually have the app on their phone, and then they can see what their partner's blood sugar was. So the other day I saw a patient in the office, and the wife was kind of in the waiting room, and she's knocking on the door. His blood sugar is 65. He needs some juice, and then meanwhile the patient was saying, oh, my blood sugar is 65. I need to have some glucose tablets. So that's pretty exciting. And then we now have what we call closed loop system with the insulin pump and the continuous glucose sensors. Medtronic is the first to bring this to market. We call it an artificial pancreas, but basically the insulin pump and a continuous glucose sensor are talking to each other. So when the blood sugar is going low and drops below 60, the pump turns off. If someone's going high and their blood sugar is elevating, the pump knows to give that person more insulin. So again, this has been a game changer as far as managing people who need to be on multiple daily insulin injections, or kids or teens, anyone with type 1. They basically can wear their sensor and wear their insulin pump, and if everything's working correctly, they can have really good blood sugar control. Wherever there's more technology, then of course there can be room for errors as well. But in general, this technology continues to improve, and the demand has been great. So great that Medtronic's having even a hard time keeping up with demand. So, and then the last thing, this Freestyle Libre Pro, or the Freestyle Libre, is a little patch that someone puts on the back of their arm. This system costs about $400 total, and is covered by Medicare if someone's on 4 times daily insulin injections. But basically, again, it's another continuous glucose sensor. So if someone wants to see what their blood sugar is, they just wave the transmitter over their patch, and it'll tell them what their blood sugar is. And you can leave that patch on for 14 days. So it eliminates the need for finger sticks. And this, the other continuous glucose sensors are about $3,000. This one's about $400. So we're going to see this price come down, and this technology to be more and more affordable. So this is where, again, you can advocate for yourself and ask your physician if you can have one of these Freestyle Libre Pros. Freestyle Libres, if it's not covered, the price tag isn't too hefty. So I would like to, before Dr. Shum comes up and talks more about feet, I would like you all to know that at Torrance Memorial we have a wonderful diabetes self-management program I talked about. They'll reiterate the things that we talked about: insulin resistance, diet, exercise, A1C, and they talk more specifically about medications. And the studies show that when people with diabetes participate in a diabetes self-management program, that generally they do better. Their hemoglobin A1C comes down, they're empowered, they know how to take action, they know how to advocate for themselves with their physicians and with their daily health care. So I would like to encourage any of you who have a friend or yourself with diabetes to take advantage of a diabetes self-management program. And with that, I'll finish, and I'll allow Dr. Shum to come up and talk to us about feet. Thank you.
All right. Well, thank you very much, Dr. Williams. I'm always amazed at what I learn when I come to these things. So I'm going to introduce Dr. Shum. She earned her degree in podiatric medicine from Temple University in Philadelphia and completed her residency training at Cedars-Sinai Medical Center in Los Angeles. She then completed a fellowship at the Combined Amputation Prevention Center at Sherman Oaks Hospital and Western University of Health Sciences program specializing in limb preservation and wound care. Dr. Shum is the medical director of the Amputation Prevention Center at Torrance Memorial Medical Center. Her interests include the treatment of venous stasis leg ulcers, arterial ulcers, diabetic foot infections, diabetic foot ulcers, reconstructive foot and ankle surgery, and hyperbaric medicine. Dr. Shum has written numerous publications on wound care and the diabetic foot. She has also presented posters at national meetings related to limb salvage and diabetic Charcot reconstructive foot surgery. Please welcome Dr. Shum.
All right, thank you very much for coming this evening. So I'll be talking about diabetes and how that can affect your feet. A few other topics of discussion is how do diabetic foot complications arise, preventative foot care, and when should you seek care. So the diabetic foot is a limb affected by varying degrees of neuropathy, deformity, and peripheral vascular disease that can cause non-healing ulcerations leading to infections. If untreated, it will end with either minor or major limb amputation. The scope of the problem is pretty enormous. Every 20 seconds, somewhere in the world, an amputation is performed as a consequence of diabetes. Diabetes is the #1 cause of amputations, more so than landmines and wars. 85 to 90% of non-traumatic amputations occur in patients with diabetes. So up to 25% of patients with diabetes will develop a foot ulcer over their lifetime. Every 1.2 seconds, someone in the world develops a diabetic foot ulcer, and 50% of those ulcers will get infected. 80% of major limb amputations are preceded by an ulceration. So how do complications arise? There are a constellation of symptoms that arise and contribute to the pathogenesis or the development of diabetic foot ulcers. The first complication that typically arises from having diabetes is peripheral neuropathy. And we will look at 3 specific types of neuropathy and how each one affects the foot. So peripheral neuropathy, also known as nerve damage, are the most prevalent chronic complications of diabetes. The principal risk factor for neuropathy is hyperglycemia. By the first diagnosis of diabetes, approximately 13% of patients will already have neuropathy. And after 10 years, approximately 50% of patients will develop neuropathy. And the progression of neuropathy can be retarded by tight glycemic control in patients. So, the types of neuropathy. The first one we'll talk about is sensory neuropathy. This is where patients have lost their protective sensation. They've lost the gift of pain. So when they step on a hard object or something punctures their foot, or if there's pain as a result of rubbing from, let's say, ill-fitting shoes, they're not able to detect this painful stimuli. And this can lead to further problems like skin breakdown. The other type of neuropathy is autonomic neuropathy. These patients, they develop very, very dry skin. And the reason being is that the nerves that control the sweat glands in the skin are not functioning properly. So the body's not able to regulate the skin temperature well. And so what ends up happening is that there's lack of moisture in the skin, and these patients, they develop chronically dry skin. And as you can see in this photo, these patients, you can get cracks or fissures in the heel. And next is motor neuropathy. The effects of motor neuropathy occurs relatively early on, and it leads to foot muscle atrophy with the development of hammer toes and associated increase in plantar forefoot pressures. With motor neuropathy, the fat pad on the bottom of the foot, which is naturally there, it begins to atrophy or thin out, and it causes the bone on the bottom of the foot to become more prominent, and it feels very, very bony. What ends up happening in motor neuropathy is that the intrinsic muscles in the foot, so the smaller muscles in the foot, they are controlled by nerves, but the nerves are not functioning anymore, and therefore the muscles become weaker over time. So then the muscles and the tendons that originate in the leg, they begin to overpower the muscles within the foot, and it causes the toes to become deformed. The tendons, they pull on the top of the toe, and it causes it to buckle up or hammer. And then it moves that metatarsal head down, which causes the increase in plantar pressures on the bottom of the foot, or the bone becomes more prominent on the bottom of the foot. So with neuropathy, a callus can potentially develop. With motor neuropathy, the muscle tendon imbalance develops, leading to the deformity and increase in plantar pressure points. Your body tries to protect itself by forming thicker skin so that it doesn't break down. But with autonomic neuropathy, this leads to very, very dry skin. So with a callus, it can become thick and dry fairly rapidly. And when you have sensory neuropathy or the inability to feel pain in your foot, the presence of a thick callus can go unnoticed and untreated. And if you have normal sensations in your feet, you would probably alter the way you walk or find more comfortable fitting shoes, or change shoes, or have the callus taken care of if you were to feel pain. But unfortunately, with sensory neuropathy and in general peripheral neuropathy, these things go unnoticed. And so something common such as repetitive stress associated with day-to-day walking in the presence of peripheral neuropathy and a callus can lead to skin breakdown very easily. And in this pedobarograph, it is a pressure-sensitive map that is used to visualize and measure the areas of high pressure in this particular foot with some deformities. And as you can see, there is increased pressure in two locations as marked by the red color. With normal walking, it's actually possible for these two areas of high pressure to break down if the patient's not wearing appropriately fitting shoes, because the skin can only handle so much stress before it begins to break down. And in this picture, a person who has developed contracture in the toes or hammer toes, they can develop areas of high pressure, as I mentioned, on the bottom of the foot, or even friction on the top of the toes if ill-fitting shoes are worn. External trauma to the foot, such as a puncture wound or a sharp cut, can also lead to the breakdown of skin. So shoe-related trauma is probably the most frequent precursor to the development of foot ulcers. These ulcers, they tend to develop on the medial side of the foot, so where the arrows are pointing, over the first metatarsophalangeal joint, or over the tops of the toes. Now, in the presence of a diabetic foot ulcer, impaired blood flow is an independent risk factor for an amputation. Peripheral arterial disease affects patients with diabetes in a few ways. One is through the buildup of plaque within the arteries that can reduce the amount of blood flow or even block the blood flow in the artery. This commonly affects the blood vessels in the pelvic region, the thigh, or the lower leg. The second way peripheral arterial disease affects patients is through the development of calcium within the walls of the blood vessels. And this impairs the transfer of oxygen and nutrients from getting in and out of the blood vessels into the tissue. So you can think of calcium kind of like a barrier or a chain link fence that's encasing the blood vessel. Instead of having a soft, pliable blood vessel for nutrients and oxygen and red blood cells to move freely in and out of, it encounters this hard calcium, this physical barrier that's blocking the transfer of essential nutrients and molecules that would normally bathe the tissue around the wound. And if you look at this picture, this is an X-ray of the foot, and you can definitely see the metatarsal bones and the digits within the foot. But if you look in between them, you can actually see calcium, the calcified blood vessels that's traveling in between all of the metatarsal bones and even going all the way to the little toes. So that's not normal. We should not be able to see blood vessels on an X-ray. So the longer it takes a diabetic foot ulcer to heal, the increase in likelihood of developing complications like an infection and an amputation. Now, diabetes is responsible for a variety of problems. It's a disease process that can lead to neuropathy, an ulceration, vascular impairment, or poor blood flow, which leads to a non-healing ulcer. And as I mentioned, the longer it takes an ulcer to heal, the increase in likelihood of developing an infection and amputation. We call this process the stairway to an amputation. Now, getting diabetic foot ulcers to heal poses very significant challenges because treatment has to be multifactorial. This includes pressure reduction, ensuring adequate blood flow, and tissue perfusion, the eradication of infection, and correcting the underlying deformity. All of these factors have to be addressed at the same time to effectively heal these wounds. Now, I will show you one graphic picture this evening, so if you're a little bit squeamish, you might want to turn away. But this is an actual diabetic foot ulcer. This patient, he developed diabetes approximately 7 years ago. He has peripheral neuropathy, and as you can see, the big toe, there's actually a contracture there, as well as the second toe. There's a callus over one of the joints on the big toe, so that tells me that there's some pressure going on there. And certainly with enough pressure, in this case, the gentleman wore some tight-fitting shoes that weren't fitting properly. It rubbed on the top of the second toe, and it has led to an ulceration. And this particular patient also has impaired blood flow, poor blood flow. So when you combine poor blood flow with an ulceration, these wounds, they tend not to heal very rapidly. And if you don't seek treatment in time, an infection can develop. And as you can see, this toe is probably 3 times the size of what a normal toe looks like. And so unfortunately, this patient ended up with an amputation of the toe. So, going back to the theme of tonight's topic with diabetes, prevention is the key component of diabetic foot care because of the lack of treatment to target underlying nerve damage. It is crucial to screen for symptoms and signs of diabetic neuropathy, and prevention of diabetic neuropathy focuses on glucose control and lifestyle modifications. Optimizing glucose control as early as possible to prevent or slow the progression of peripheral neuropathy is key. Studies have shown that patients with well-controlled type 1 diabetes reduces the incidence of polyneuropathy or peripheral neuropathy. There's a 78% risk reduction. In patients with type 2 diabetes, enhanced glucose control reduces the risk of developing neuropathy modestly, approximately 5 to 9%. And as Dr. Williams mentioned earlier today, it's because a lot of times it takes years before patients are finally diagnosed with diabetes. They will have impaired insulin resistance for many, many years before they're finally diagnosed with diabetes. And during that time, peripheral neuropathy could have already developed. So lifestyle modifications. There's 4 studies that I've highlighted here that shows that either exercise alone or exercise and diet can modify the natural history of diabetes related to peripheral neuropathy. This last particular study, the University of Utah type 2 diabetes study, showed that there is actually reported nerve regeneration with exercise and diet. So pain management when it comes to peripheral neuropathy. Unfortunately, there's no treatment to reverse peripheral neuropathy once it's developed. And peripheral neuropathy, not only can it be inclusive of the loss of protective sensation or numbness in your feet. Many patients will describe burning sensations, pins and needles, sharp shooting sensations. It feels like my feet are on fire. Those are all signs of peripheral neuropathy. And right now there are 2 different medications that have FDA approval for management of diabetic neuropathy. There are certainly other medications that help manage neuropathy, but unfortunately, there is no cure. You're managing these symptoms. So steps to help your feet. First and foremost, inspection. Inspect your feet, your heels, in between your toes daily for blisters, calluses, bleeding, cracks in the skin. Watch for long or thickened or ingrowing toenails because sometimes that can cut into the flesh of your skin. It needs to be addressed. Use a mirror if you're not able to see the bottom of your foot. Elicit your family and friends to help you if you are unable to do so. And check skin for extreme in temperatures as well. Having skin that's too hot or too cold could be a sign of a problem. Overall skin care. Wash your feet daily, but do not soak them. No hot water bottles should be used either. When showering or bathing, don't test the water with your feet or your hands. Peripheral neuropathy tends to affect your hands and your feet first. So what we recommend is to test the water with your elbow. You want to dry well in between the toes and apply some type of moisturizing cream every day, if not twice a day, but avoid the areas in between your toes. You want to keep that area relatively dry. We don't want the skin to break down in between the toes. And you want to trim your toenails straight across. So your socks. You want to wear well-fitted socks with your shoes. Light-colored socks should also be worn because if you were to develop, let's say, a blister, a small little cut, usually you would see a stain in a light-colored pair of socks. If you wear dark-colored ones, well, you won't be able to see what's going on with your feet. So light-colored socks can be used as kind of like a helpful indicator of any potential signs or problems. Avoid socks with seams to prevent blisters and abrasions. Socks with seams tend to bunch up as well, and we don't want that to happen within your shoe. You want to change your socks daily. And you always want to remove your socks and shoes when you visit your doctor. So we call it knock your socks off. So your shoes. You want to check your shoes before putting them on for any rocks or foreign objects that shouldn't be there. Your feet should be measured every time at the time of shoe purchase. And you want to purchase your shoes towards the end of the day. The reason being is that we have a tendency to develop swelling in our legs and our feet towards the end of the day. So you want to make sure that you capture that foot size when you buy new shoes. Shoes should be comfortable and easy to put on at the time of purchase, and you want to wear leather shoes with adequate room, a rounded toe box. And this is an example of a shoe with a relatively round toe box. Running or athletic shoes are also best for recreational walking. And for some patients, prescription shoes and accommodative inserts may be necessary, especially if you have peripheral neuropathy or deformities. And I will show you an example of a shoe that's not fitting well in this particular patient. This patient was developing an ulcer on the fifth toe. You can actually see a small little red stain there. I took the insert out of his shoe, put it against his foot, and you can actually see 3 toes hanging over that shoe insert. You can also see around the middle of the foot, that insert's not covering any part of the middle of the foot. So this shoe is entirely ill-fitting. It's too narrow and it's not wide enough. So when this patient is wearing his shoe, everything's just being bunched up inside. So that's an ill-fitting shoe. Some general principles. Do not walk barefoot in the house, outside, or at the beach. I can't tell you how many times I've seen patients who walk barefoot on, let's say, an outdoor pool deck or going to the beach on asphalt, walking around their neighborhood, and they come back with a burn on the bottom of the foot. You always want to wear shoes to protect your feet even inside the house. Have a separate pair of shoes for inside the house if necessary. And the reason being is that in this particular x-ray, this patient actually stepped on a needle, an insulin needle. They had no idea that there was a needle embedded in their foot. And this happened inside the house too. Most frequently it does happen inside the house. So your house may not be safe, so always wear shoes inside your house. Do not use acids or chemical corn removers that can burn the skin. Do not perform bathroom surgery on your own to remove calluses or ingrown toenails. Frequently, patients end up accidentally cutting themselves when they try and do something like that. And of course, you want to keep your blood glucose levels under good control. Exercise, it helps with a lot of things. It brings your blood sugars down. It helps improve circulation in your legs. So exercise is key. So when to seek help? If you have diabetes, your feet should be examined by your doctor at least once a year. You want to make an appointment with a podiatrist or a specialist or your internist if you develop any foot pain, redness, sores, ulcers that do not heal in a timely fashion. if you were to develop a cut or a sore, really the timeliness at which that is taken care of is key in preventing complications from arising. Now, this is a guideline that experts have developed to risk stratify patients who have diabetes and what their recommended treatment plans should be, and the suggested follow-up with either their internist or specialists. So if you have diabetes and only the diagnosis of diabetes alone with no loss of protective sensation, no peripheral arterial disease, or no deformities, you're categorized as low risk. In general, you should be evaluated annually by your internist or specialist. Patients in risk category 2, they have the diagnosis of diabetes, they have loss of protective sensation, and they may or may not have some type of deformity on their feet. These patients should be evaluated every 3 to 6 months. And some of these patients, they may need accommodative or footwear or prescription footwear to help prevent any development of wounds on their feet. Sometimes surgery may also be considered to address the underlying deformity. Patients in risk category 2, they have diabetes with peripheral arterial disease, and they may or may not have the loss of protective sensation. For these patients, we consider prescriptive shoe wear for them, and also an evaluation by a vascular specialist to assess their circulation. And these patients should be seen every 2 to 3 months. And if you're at the highest risk of developing foot complications, these are usually patients who have had an ulcer or have had an amputation in their foot, then they should be seen more often, every 1 to 2 months by a specialist. And these patients also need to have prescriptive footwear and be seen by a vascular specialist as well to evaluate their circulation. So in general, a simple blister, nick, cut, or a wound should not be ignored. Patients with diabetes can have poor wound healing potential, which may lead to delayed healing, the development of an infection, and an amputation. But the good news is that 80 to 85% of patients with diabetes who have limb-threatening conditions are treatable, and even more are preventable, and this is according to the World Health Organization. So I'd like to thank you.
All right, we're going to take a little break now so we can give you some time to stretch, but more importantly, the Miracle of Living people will be walking around with cards and pencils that you can write down your questions. They'll be brought up here, and then this is what we'll direct to the panel. So we're going to take about a 10-minute break, and then we will reconvene. All right, some of these questions were directed at the specific physician, so I'll direct those. Otherwise, I'll just have you guys chime in. So this one is specifically for Dr. Williams. If a person is insulin resistant, can that person take more insulin to help?
Oh yeah, so we do, so if someone's insulin resistant, you can use more insulin. So if you're diabetic and you're on insulin, you can overcome typically the insulin resistance with insulin. The challenge is when you use more insulin, it is a growth factor for fat cells, and it stimulates your appetite and may have other growth properties. So we do see people who are insulin resistant. So someone who's insulin sensitive, their total daily insulin requirements may be 20 units per day, with 2 or 3 units per meal. I've had some patients who are so insulin resistant that they're using 20, 30, or 40 units of insulin per meal. So they really they battle obesity. So it's really a challenge. And some people have antibodies to insulin, so they can't, the antibodies interfere with the insulin being able to work. But the best way to tackle insulin resistance is exercise. So even short spurts of exercise, 10 minutes of walking stairs or brisk walking, does make your body more sensitive to insulin.
All right, now this is specifically for Dr. Shum. What do you do to increase blood flow in your foot? What does it mean if the feet swell? And can arthritis have symptoms just like diabetic problems? What are the best materials for socks?
Mini memory test as well.
Right,
so.
right. So what can you do to improve circulation in your feet? The best thing to do is to exercise, to walk, because just by moving your calf muscles, that actually helps move the blood flow up and down your leg.
What if your
edema, right?
yes? What if the feet swell?
What if the feet swell? Yes, that can be a sign of peripheral vascular disease. It could mean that you have pooling of the blood in your lower leg, so maybe the veins are not working quite as properly in moving the blood flow back up. It can also be a sign of a systemic problem, heart or kidney issue as well.
Then can arthritis have symptoms like the diabetic foot?
Arthritis can have some similar symptoms, especially if you have arthritis, let's say in the spine or in the hip. Sometimes patients can develop some form of neuropathy or pain radiating up and down the leg. So yes, it can have similar symptoms to neuropathy or diabetes.
And what is the best material for the socks?
Best material for the socks is something that wicks away moisture very well. We tend to sweat in our feet, so moisture wicking material, so not 100% cotton nowadays, but they have things with nylon, with Lycra, that are very effective in removing sweat so that you don't develop blisters in your feet.
There's a fabric that I've become familiar with called Celliant. Have you heard of that? Celliant, Celliant.com. And some very smart young people put thermoreactive minerals in a fiber, in the threads, and then those minerals react with your body heat and then generate infrared rays. And so it's been shown to help neuropathy and increase peripheral circulation and blood oxygen levels in your feet. And they sell the socks for like $20. And I have cold feet, and it does really, they keep your feet warm, and they're great. They developed this material originally for thoroughbred horses to improve exercise capacity. I know if you want to know how to treat yourself, look at the thoroughbred literature. But anyway, anyway, it's pretty cool. So I have people, they sell booties and mattress pads and blankets, and it's pretty reasonably priced. So it's called Celliant.com. Yeah.
It's good to know.
Yeah, it's awesome.
All right, so why is my glucose high in the morning and okay the rest of the day? Another question similar, what's the advice for battling the dawn effect, high glucose?
So this aggravates people to no end. They say, I go to bed at, my blood sugar's 100, and I wake up in the morning and my blood sugar's 150, and I did not get up and eat at all. So I mentioned briefly in my lecture about glucagon, and glucagon is stored, basically long chains of sugar. Glycogen is stored. Glucagon releases the stored sugar from your liver and a little bit from your kidneys. So the dawn phenomenon is our body gets ready for the day, our stress hormones go up, our cortisol level elevates, and we abnormally release sugar into our bloodstream. So it's another part of the diabetic profile. They have inappropriately elevated levels of glucagon, which result in abnormal dumping of sugar into the bloodstream, especially in the early morning hours. And that often is one of the first abnormalities that we'll see in someone's blood, is that their morning blood sugar just keeps going up and up. It responds to a medicine called glucophage or metformin. It also, that first morning blood sugar responds to weight loss and decreased caloric intake. But it's stubborn, and it took years, if not decades, to elevate, and then it takes, consistent changes in habits and dietary intake, exercise, and weight loss, and it does come down. It's stubborn.
Okay. Should, if I have athlete's foot, should I spray Tinactin between my toes?
Yes, that's fine. That's actually what I recommend patients to use as well. I usually have patients use a spray as opposed to any type of topical cream or ointment because, again, we want to keep the web space relatively dry. So an alcohol will kind of air out and dry things up more so than a cream or an ointment. So yes, that's okay to do that.
Does low blood pressure affect your chances of diabetes? And if you have prediabetes, does that mean you will become diabetic, or can you prevent it?
Great questions. So low blood pressure is usually very protective for cardiovascular disease, risk of stroke, developing atherosclerosis, and it is not related to diabetes. So someone still could become diabetic even if they have low blood pressure. Generally, if people are overweight and sedentary, we do see more hypertension in those people, especially. So weight is a big causal factor in elevated blood pressure. So, they're sort of indirectly linked, but having low blood pressure in general is very protective for cardiovascular complications. And then absolutely, if you have prediabetes, you can prevent diabetes. You can delay the onset of diabetes. You can have an impact on reducing the degree or quote unquote seriousness of your diabetic condition. So absolutely, daily choices have a big impact on whether or not you could develop diabetes or how difficult your diabetes may be to treat.
And just from the primary care standpoint, we've been talking about prediabetes for at least 10 years. And when I first started hearing about it, I thought, oh, it's just another diagnosis. But I've learned in that period of time, it's really the best way to say, let's not wait till somebody's diabetic. There's so many things that you can do in those years prior that you never have to have it. So that's the key now for knowing, as Dr. Williams talked about, knowing what your sugars are, knowing what your cholesterol is, knowing what your A1C is. Don't wait till you're diabetic. You can do something now and we really need to be doing something now. All right, should running be limited for diabetics or marathons okay?
Oh, that's a difficult question. Running should not be limited in patients with diabetes, but you do have to be cautious if you are going to run a marathon and you have diabetes, especially peripheral neuropathy, because frequently with marathon runners, they will come back with blisters, black toenails, toenails that have fallen off, and maybe little cuts and wounds on their foot because of trauma from running. So that is something that you have to be extremely cautious about. I never want to discourage anyone to not do any exercise, but you do have to be extremely careful with that type of activity. Prolonged running, doing a marathon where it's 26.2 miles, that may be a little bit tough on your feet. That's not to say that patients who have diabetes don't run marathons. I know a lot of patients with diabetes who do, but they monitor their feet and they take care of their feet very, very carefully. So they watch for any little signs and symptoms of problems that may develop, and they kind of know their limits and thresholds as well.
And Dr. Williams, I'll ask you to kind of address, I would think that a diabetic training for a marathon, they've just got to be smart about all of their protein and...
Oh yeah, And again, we're talking, there's two different kinds of diabetes, and an insulin-dependent diabetic. Some of, the Olympic athletes who have been type 1 diabetics almost have a full-time diabetologist helping them manage their diabetes. So that type 1 and diabetes can be very tricky with exercise. It is getting easier with the continuous glucose sensors and the closed-looped pump systems. And yes, of course, with type 2 diabetes, if you're increasing your exercise, almost always you can reduce your medication. You'll be more prone to low blood sugars. So you really want to work with your physician proactively about reducing medication, insulin, and some of the other medicines. You really have to work with your physician.
Are one-touch Ultra 2 blood glucose units accurate? My blood this morning was 119, but when they tested it here, it was 82.
Yeah, so a one-touch meter, most of the home blood glucose monitoring devices are very accurate within 2, 3, 4 percentage points. Typically, the FDA allowable range is about a 10% variation, but most of them on the market are about within 2 to 4%. Some of the generic meters are less accurate, and some of the insurance companies are pushing the generic meters. But we talked a little bit about the dawn phenomenon, and that first morning blood sugar will be high at 119, and that can be the most stubborn, that can be your highest reading, except immediately post-meal. So that's still, I would still watch that person for diabetes, look at their hemoglobin A1C, make sure it's okay, but the blood sugar can be high in the morning and then come down later during the day. That's a very typical pattern.
Is yoga good for foot strength?
Yoga is good for foot strength, and it's also good for kind of loosening up your joints as well. And with peripheral neuropathy, your joints can actually stiffen up over time. So it is good to be kind of limber and to be able to stretch and move your joints. So yes, it is good.
I have a patient here that went to the clinic. They did a feather test and a needle test, and the patient flew off the table, hit the back of her head on the wall.
So we use those tools to test for peripheral neuropathy. And in certain patients who develop peripheral neuropathy, they actually develop like a heightened sense of sensation. So even with like a light feather, it will come off as something that maybe will feel painful for certain people. And those are all signs and symptoms of peripheral neuropathy. Other tools that we use are the monofilament. Sometimes we use a tuning fork to see if you can feel the vibrations within a tuning fork. Other times we may test for a sharp, dull sensation to see if you can detect the two different types of textures. What we also do is we check your proprioception as well, whether or not you can tell if your toe is sticking up or pointing down. Patients with peripheral neuropathy, believe it or not, sometimes they lose that sensation, or they lose that ability to detect where they are in space. And that's when patients' balance tend to also be affected as well.
Again, it's to me, the nervous system is just amazing. There's different nerves that detect temperature and vibration. So depending on which nerves are being damaged by peripheral neuropathy, you can have all sorts of different ways that neuropathy presents. You have no feeling, you can have too much feeling. It's really kind of a nightmare. All right, can someone with diabetes, will the diabetes cause severe swelling in the upper back and the spine as well as the upper abdomen, but nowhere else?
Not that I'm aware of. I think that's more of maybe a different type of systemic issue.
Yeah, not specifically. Yeah, that's unusual.
Okay. So these questions are kind of related. This patient received a prescription for orthopedic shoes, and he wanted to know if this is helpful in the diabetic person. I know you guys kind of talked about this.
Yes, a lot of times orthopedic shoes or prescription shoes can be very, very helpful in patients with diabetes because it can prevent ulcerations and the development of complications. What's different about orthopedic shoes compared to an off-the-shelf shoe that you were to buy at a department store or a running shoe store is that they will measure your feet for these orthopedic shoes, and they ensure that there's a deep toe box, a wide toe box, more so than the shoes that you would find off the shelf. Additionally, a lot of times with the orthopedic shoes, it may come with an insert, and these inserts have multi-density foam. And what's great about that is that if you were to have bony prominences on the bottom of the foot, these types of inserts would actually accommodate for the deformities, thereby decreasing the chance of developing an ulcer or slowing down the development of a callus. So they are actually very good.
What helps heal a small blister on the bottom of the foot?
If it is related to diabetes, first and foremost, we want to make sure that your blood sugars are under very good control. And as I also talked about in the presentation, we want to make sure that there's no infection there either. Circulation is key as well, and also pressure reduction. So we call it the VIPs of wound care: vascular assessment, infection control, and pressure reduction. Those are the three key components in addition to tight glycemic control and good nutrition. All of these factors must be implemented all at one time to get this wound to heal, because if one of those components is not addressed, this wound can take a long time to heal in patients with diabetes. We find that they have impaired white blood cells that don't function properly, so they're not able to fight off infections well. They're not able to actually heal as well. It impairs the actual wound healing process. So those factors are all key into getting the diabetic foot ulcers to heal up.
All right, this patient for 8 years has had to take prednisone for an autoimmune disease. So they developed prediabetes. Now they've been diagnosed with diverticulitis and were told to eat only white bread. What can this person do?
That's tricky, but it is tricky. I would see a nutritionist. You can have, with prediabetes, you meet criteria for having a covered nutrition consult. Is covered by Medicare and most insurances. So you really need to see a nutritionist who can come up with a meal plan and foods that are acceptable, that also can be managed as far as reducing your risk of developing diabetes.
I have diabetes too. Is it normal to have burning, shooting pains in the top of my foot and up the legs? Any suggestions for help in easing this discomfort? He also has swelling at the top of the feet and the legs up to the knees.
So those sound like symptoms of peripheral neuropathy. And once you have the diagnosis, or once you have peripheral neuropathy, it is very difficult to manage those symptoms. Some medications work better than others for certain patients. And I listed 2 of them, but there are actually more medications out there that treat neuropathy. Depending on how you react to those medications, they can be helpful in managing the symptoms of peripheral neuropathy. Exercise in general tends to also help as well, because not only does it make you kind of move, use your muscles, it kind of takes your mind away from the pain that you may be feeling. So it's part of the whole pain management of peripheral neuropathy. Unfortunately, there's no one thing that's going to work very well in managing those symptoms. It's going to be taking care of your blood sugars, make sure they don't fluctuate too much, and also trying medications and other types of pain management modalities to help with that pain.
The other thing that I look at in my patients with painful diabetic neuropathy is I always try to make sure that B12 levels, that you're optimized on your B12 levels, and about 50% of the population has some variation in what we call methylating your B12 and your folate levels. So there's a vitamin that's methylated folate and methylated B12. A brand name is called Metanx, METANX, and that can help reduce the pain. And then I do use alpha lipoic acid.
Yeah, and Metnex as well.
Yeah,
Yes.
Metnex, and then over-the-counter alpha lipoic acid can help reducing the swelling. Swelling can be a side effect to some of the blood pressure medicines, and then elevating your feet above heart level, ideally like 20 minutes, ideally twice a day, but reducing the swelling can help. And then your blood sugar control. So I would say you might have more, I don't have, in general, when we do those things and the patient's blood sugars are controlled, the neuropathy does get better.
Right.
I mean, the neuropathy is usually the worst when the blood sugars are high.
Yes.
It's been my experience, yeah.
So we have some diet questions now. Is the keto diet a good diet to go on to prevent diabetes?
So the keto diet, so basically, there are a couple schools of thoughts, but I would say in general, the literature does favor a keto diet, which is higher fat, higher healthy protein, lower carbohydrate. So you do have to be careful. You have to make sure you're not type 1 diabetic. You should have physician input. There was just a study published in the last couple weeks in the Journal of Clinical Endocrinology and Metabolism that did show a keto diet helped reduce the fatty liver and liver disease of diabetes. So it is definitely gaining favor. You have to work with your physician on medication management. And the other thing that's gaining popularity and the science behind it is intermittent fasting. So how many of you have been hearing about the intermittent fasting? USC put out a program called ProLon where they did a 5-day fast mimicking diet, but people can, with physician guidance, use very low calorie intake for a weekend. Or what I talk to my patients about is 16 hours a day, 0 calories, and then you consume all your calories in an 8-hour period of time. And so there's more ketosis in that period of time. You do have to, again, if you're insulin dependent, it can be very tricky. Your medications, if you're diabetic, do have to be changed or monitored so that you don't go low. But in general, in this country, probably the worst thing that we did for obesity, and the term diobesity, diabetes and obesity are related, is make food available 24 hours a day, continuously available. It's always food, 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 food. Food at breakfast, lunch, dinner, 10 p.m., 2 a.m. It's always on the TV. It's always everywhere. Probably again, the access to food in this country has caused a diobesity epidemic. And along those lines, just from a business perspective, food is a huge industry in this country. And every day, twice as many calories are produced as we need to maintain our weight. So think about that. They want to sell us the food. They've just made 200 billion calories, but the country only needs 100 billion calories to maintain our weights. So there's huge economic forces behind the diobesity epidemic. And the Obesity Society has a meeting every year, and again, sometimes I go to that meeting, but they do talk about the companies
reducing advertising to kids and all this, and it's still, I mean, we still have to be, politically active and involved because it's big business, big marketing, big money. So,
My personal bias is I think the amount of sugar that we've used in the last 100 years is poison. It's essentially our bodies just don't work like they're supposed to. What is your opinion of the 100% plant-based diet?
it's healthy. It's healthy. It's very healthy. Again, you want to probably work with the nutritionist, make sure you're getting sufficient amounts of protein. You have to balance your proteins. But I would say, in general, the scientific data supports that plant-based diets, those individuals have less heart disease, less cancer. Dean Ornish, who is probably many of you have heard his name, is one of the original cardiologists who demonstrated that low-fat diets and vegan diets can actually reduce atherosclerosis. So I think plant-based diets are very healthy.
Can you manage diabetes with exercise and diet only and not have meds?
Oh, it depends on the person. So it depends on genetics, age, duration of diabetes, whether or not someone has antibodies or not, how long they were insulin resistant. So it's highly, highly individual. I always say, people, ask me, if I lose 25 pounds, will I get rid of my diabetes? I say, I don't know if it'll go away, but we call it lifestyle controlled. No matter what, it'll become better. So it's highly variable, but it always helps, reduce the amount of insulin you need, medication you need. So diet and exercise have a huge impact on what, even if you can't get rid of your diabetes, it has very big impact on the number of medications you need and your control of your blood sugars.
And I just have to echo this. People don't realize how much lifestyle changes can do. I have people that come into clinic every week that got serious about eating smart and exercising and dropped their blood pressure, dropped their sugars, came off meds. But what I see is just either too few people believe that it can happen, or they just don't have the self-discipline to do it. It works. Our bodies work if we treat them the way we're supposed to. All right, Dr. Shum, do you only treat diabetic patients or any patients with foot problems?
I treat mainly patients who have wound-related complications. Whether or not you have diabetes or not, most of my patients do have them, so I don't treat your run-of-the-mill podiatry problems like heel pain and hammer toes and things like that. But if it is related to wounds, then yes.
And any support groups at the hospital for prediabetes?
Yes, and as a matter of fact, the pre-diabetes, the diabetes education program has a pre-diabetes education program. I mentioned there's a preventdiabetes. I don't remember if it's .com or .org website. Beach Cities Health District has a prevent diabetes program. The YMCA has prevent diabetes programs. So in this area, we have the Y, we have Torrance Memorial, we have Beach Cities Health District. They all have diabetes prevention programs.
All right, well, I think this has been a really good evening tonight. I know I've learned a lot. Thank you very much, doctors, for joining us.